Okay, good evening to everybody. I am Paola Rossi. I'm professor of physiology at the University of Pavia. I work in the Department of Biology and Biotechnology of the University of Pavia. And before to start, I want to remember you some technical details. So if you wish to follow this webinar in English, you have to you don't need to change your normal Zoom settings. If you wish to follow in Italian or Spanish, click on the interpretation button in Zoom and then choose your language. To mute the original audio, you can choose the mute original audio option of the same button. On mobile phone and tablet, you need to press the More button to display the interpretation button. Chi desidera ascoltare il webinar in inglese non ha bisogno di cambiare le proprie impostazioni di Zoom. Chi desidera ascoltare la traduzione simultanea deve cliccare sul pulsante Interpretazione e poi sulla lingua di traduzione desiderata. Per silenziare completamente l'audio originale si può cliccare su Silenzia audio originale. Sui telefonini e sui tablet il pulsante interpretazione va richiamato sullo schermo toccando il pulsante altro. Okay, so I think that we can start. Before all, I am honored to be the first to introduce the first conference and I want to thank the European Society of Neurogastroenterology and Motility to invite me to be the moderator of the first session of the international webinar course, Microbiota and Gut-Brain Connection, a new frontier in neurogastroenterology. As I said before, I am Paola Rossi. I'm professor of physiology at the University of Pavia. I am the director of the Human Nutrition Master at the University of Pavia, and I'm the group leader of the Neurobiology and Integrated Physiology Lab of the Department of Biology and Biotechnology. So it's a big pleasure for me to introduce you Professor Timothy Ted for Friends Dinan as the first speaker. Professor Dinan is professor of psychiatry at the University College of Cork. He is the director of APC Microbiome Institute of the University College of Cork. He is one of the major international experts on the gut microbiota brain axis, and actually he coined the term psychobiotics in 2013. From that moment started a new exciting view about the brain and the connection with gut. Professor Ted Dinan will talk about advances in human microbiome science, gut-brain connection. Okay, Ted, good listening to you all, and you can share your screen when you want.
Great. Can you see my slides now, or?
Yes, we can, sir.
Okay, perfect. But thank you very much for that introduction. It's a pleasure to be here this evening. What I would like to do is look at the way in which gut microbes communicate with the brain, and also then look at the implications of that for psychological and neurological processes. So if we start off and, we ask ourselves, do microbes actually communicate with the brain? Now, when I started off working on the brain-gut axis, and I did that, a long time ago, it was in the late 80s I began working in this area. There were many studies, but nobody included microbes in the communication between gut and the brain. We viewed them as commensal bacteria. They did us no harm, but we didn't really perceive them as doing us any good either. So it's really only within the last, I would say, 18 years or so, that gut microbes are viewed as an important part of the brain-gut axis. And of course, the collection of those microbes within the gut we refer to as the gut microbiota. Now, the gut microbiota in humans, in an adult, weighs over 1 kilo, probably 1.5 kilos, and most of those microbes are bacteria. But of course, we have viruses and we have fungi and we have other microorganisms as well. But in terms of volume, undoubtedly, the bacteria are the most important. And the bacteria contain a vast amount of DNA, and many of those genes in the bacteria produce molecules that our brain and other organs in our body require. If we were to take all the DNA that the bacteria have, of course, it wouldn't all fit in our cells because there's so much bacteria within the DNA. Now, at this particular point in time, we know of over 1,000 different strains of bacteria within the intestine. So, given that, how do these bacteria, well, first of all, how does that microbiota actually evolve throughout our lifespan? And it evolves from a relatively simple structure when we are babies postnatally to a much more complex structure when we're adults. And there are changes in old age as well. So the initial microbiota is largely determined by how we were born. A baby born naturally through the mum's vagina picks up lactobacilli as it passes through the birth canal, and they are the dominant bacteria within the initial microbiota that is formed in the baby. Now, if a baby is breastfed and isn't exposed to, let's say, antibiotics in childhood, that microbiota remains relatively constant in the initial months. Whereas the microbiota of a baby born by cesarean section is determined largely by environmental factors because that baby doesn't pick up the microbes from its mum. Now, over the first 2 or 3 years of life, the microbiota from a baby born by cesarean section and a baby born per vagina, they tend to converge. So at about 3 years, they're pretty similar. I won't say they're identical, but they're certainly very similar. And the microbiota becomes more complex when we're in our teenage years. It develops into a complicated structure. And of course, there are certain things that can impact the development of that microbiota. For example, if a teenager is engaged in drug abuse, that will impact negatively the gut microbiota. If a teenager has a very bad diet with lots of fast food, and of course that's not unusual in the teenage years, that will negatively impact the gut microbiota as well. Now, when we're adults, the things that positively influence our gut microbiota would be, obviously, exercise has a very positive effect on the gut microbiota, and a good diet is essential for a healthy microbiota. In fact, if you were to say, well, what is the most important determinant of a good microbiota, one would have to say that exercise was the big regulator. If we are intensively stressed, and I will show you data in a few minutes, but if we're stressed as adults, then clearly that will affect the microbiota. And we know that the microbiota is affected by antibiotics and by other drugs. I mean, it's estimated that about 80% of drugs that are prescribed regularly in Europe impact the gut microbiota, and most of them have a negative impact on the gut microbiota. There are 1 or 2 exceptions, but in general, they have a negative impact, particularly drugs like proton pump inhibitors, which are widely used, obviously, in gastroenterology and in primary care medicine. Now, we all want to grow old healthily, And I want to talk later on about one or two diseases of old age, but suffice it to say that if one is going to grow old healthily, one has got to maintain a healthy, structured gut microbiota. A microbiota that loses diversity as we age is associated rapidly with frailty. So if one doesn't wish to become frail, and none of us do, obviously, we all want to grow old healthily, it is essential to have a healthy microbiota. Now, this is the cover of a Time magazine article. It was the cover of an issue of the journal, and it's saying that stress is one of the modern day curses and it, of course, is associated with so many diseases. And on the right hand side of the screen, you see Hans Selye, because Hans Selye was the first person really to link stress with physical disease. And there are so many diseases now, both psychological and peripheral. I don't like the term psychological as though it didn't include the brain. But clearly, diseases like depression, anxiety disorders, irritable bowel syndrome, stress undoubtedly plays a role in these disorders. So how do gut microbes communicate with the brain? Well, we know that gut microbes, when they metabolize certain fibers, that they produce short-chain fatty acids. And those short-chain fatty acids would include butyrate, propionate, acetate. And these short-chain fatty acids can enter the bloodstream, and they do travel to the brain, where they have the potential to act through G protein coupled receptors. But I think their primary action is actually as epigenetic regulators. Butyrate is a very potent HDAC inhibitor, so it can influence the way in which certain genes actually function. Now, another route of communication is the fact that certain microbes, particularly the bifidobacteria, can actually produce tryptophan. Now, of course, we can get tryptophan from our diet as well, but tryptophan can be produced by bifidobacteria, again enter the bloodstream, and as everyone knows, tryptophan is the building block for serotonin, and serotonin has a lot of roles centrally, including regulating mood, sleep patterns, appetite, and so forth. The other route of communication, which one must certainly bear in mind, is the neuronal route. The vagus nerve connects the gut and the brain. And we know that signals come from brain to gut via the vagus nerve, but signals also go from the microbiota to the brain via the vagus nerve. And a few years ago, in a paper in PNAS, we showed that a certain microbe could only communicate with the brain when the vagus nerve was intact, and that if we severed the vagus nerve, that microbe could not communicate with the brain. So these are some of the routes. Now, we do know that microbes also have an influence in, let's say, regulating microglial function centrally. We also know that they play a very significant role in regulating the hypothalamic pituitary adrenal axis. So the main stress axis, the hypothalamic pituitary adrenal axis, is partially at least regulated by the gut microbiota. Now, microbes have the amazing ability to produce most of the common neurotransmitters. We've written quite extensively about lactobacilli and GABA, and all lactobacilli produce GABA to varying extents. Some of them produce a lot of GABA, and some of them produce less so. But other neurotransmitters like dopamine, noradrenaline, acetylcholine, they all can be produced by microbes in the gut. Now, I don't for a second believe that the neurotransmitters enter the bloodstream and go to the brain. I don't think that happens. because they wouldn't cross the blood-brain barrier. I mean, GABA cannot cross the blood-brain barrier, so it's unlikely to be transmitted to the brain. But that doesn't mean that it can't influence the brain in an indirect way through the enteric nervous system or by perhaps even the vagus nerve. So they are important regulators locally. Now, this is a kind of a summary of data from John Cryan and I over the last few years, where we've shown that myelination of neurons in the prefrontal cortex is very much under the control of the gut microbiota. And that if you dysregulate the gut microbiota, these myelination patterns in the prefrontal cortex are altered. Another important role centrally, we know that the brain does form new neurons. I mean, there are stem cells or progenitor cells in the hippocampus, and they form new neurons. And we have shown that when that the gut microbiota regulates the formation of new neurons from these progenitor cells. Connections between neurons, synaptic connections, are very much altered influenced by the gut microbiota. Now, suffice it to say that the gut microbiota can influence behavior in a variety of ways, because we found that germ-free animals, if you raise a mouse without a gut microbiota, its behavior will be very abnormal. It will tend, for instance, to interact with inanimate objects in preference to interacting with other mice. Now, we know that mice are sociable creatures. They're like us, they're sociable. But if you give a mouse with a no gut microbiota the opportunity to interact with a pen or another animal, it's as likely to interact with the pen. So its behavior is definitely altered. Now, some of the diseases that have been associated with alteration of the gut microbiota, there's an enormous amount written about obesity, obviously, and the fact that the gut microbiota is altered in obesity. Our focus has been largely, I suppose, on stress, depression, and anxiety. But in recent times, there's been quite a bit written about autism and Parkinson's disease. And of course, as we will hear later on, we also see alterations in the gut microbiota in disorders like irritable bowel syndrome. So there's a vast array, and they're just some of the conditions that have been associated with alteration of the gut microbiota. Now, I personally always view the gut microbiota as a large fermenter. It's fermenting and producing a vast array of molecules, and those molecules, some of them, as I say, can get into the bloodstream. So that's the large intestine, this large, very essential fermenter. And I'm actually intrigued by the fact that, I've had a series of patients over the last 10 years who've had, a full colectomy, a total colectomy. And, you do get interesting psychological syndromes, including quite resistant depression emerging in some of these patients. So this is just illustrating, I suppose, what I've already said, that from early childhood to old age, the gut microbiota is constantly changing, and it's changing in response to diet, in response to exercise, and so forth. So there are many factors that influence the gut microbiota, and I've mentioned some of them. Obviously, genetics is a very important contributory factor, but the living environment is as well. And we know that one culture to another, there are differences in the gut microbiota. Some of these are due to changes or differences in dietary habits and exercise levels. Obviously, disease or concomitant disease will influence the gut microbiota. And as I've said, about 80% of medications at least negatively influence the gut microbiota. So when we're talking about interventions for longevity, undoubtedly prebiotics, we'll talk about those in a minute, but probiotics and synbiotics, which are a combination of prebiotics and probiotics, can really positively impact the gut microbiota. And of course, the most radical way of altering the gut microbiota is a fecal microbiota transplant. So this is a study looking at the gut microbiota in elderly people. So there's 75 elderly people. And what you've got here, the red, it's a principal component analysis. On the left-hand side, the red circles represent healthy elderly, and the blue circles represent elderly who have diseases. And as you can see, there's a big difference between the healthy elderly and those who have concomitant diseases. And it was a group actually here in Cork. I wasn't part of it, but a group of my colleagues here in Cork who, in a paper in Nature, a few years back now, Paul O'Toole's group, were the first to show that if there was a decreased diversity in the gut microbiota with aging, that frailty followed rapidly. So you've got to keep this healthy gut microbiota to remain strong and well as one ages, or one ends up with frailty. Now, this is a study we conducted looking at some of the patients who were attending my clinic at Cork University Hospital, and we looked at their gut microbiota, and we compared them with the gut microbiota of healthy subjects, so they were age and sex matched. Now, if you look at the principal component analysis on the right-hand side of your screens, you see that the depressed patients and the healthy subjects are very different. That the depressed patients seem to lose richness and diversity in their gut microbiota. Now, why does that happen? I don't know. We specifically chose patients whose diets were not significantly altered during the depression, because that would obviously explain why they might lose diversity or richness in the microbiota. So that wasn't the explanation. Now, we carried out a study, which I must say, the results were not what I expected. We did a study in rats where we transplanted the gut microbiota from a depressed patient or a healthy subject into a rat. And in summary, we found that when the rats had the microbiota from a healthy subject, their behavior was entirely normal, their endocrinology was normal, their immunology was normal. But when they got a transplant from a depressed patient, so they had now the gut microbiota of a depressive, their behavior changed, which became more depressed-like. They showed alterations in tryptophan metabolism. Their certain immune molecules were increased. So basically, they seem to develop at least some of the phenotype, both behavioral and biochemical, of somebody who was depressed. And that did not happen if they got a transplant from a healthy subject. Now, I think it's worth making the point. I mean, clearly, we all know that you can change the genes in your cells, not readily anyway, at this current point in time. But we most definitely can change the genes in our gut microbiota. And we can do this in a number of ways. We could use probiotics that will obviously put bacteria, healthy bacteria, into the gut microbiota. We could use prebiotics, which are fibers or complex sugars that promote the growth of good bacteria. We could simply just go on a very healthy diet. There are certain components of the diet, such as fish, that will promote the growth of good bacteria. Or we could have the radical treatment of an FMT, or a fecal microbiota transplant. Now, fecal microbiota transplants, the only clinical indication for that right now is elderly patients, is usually elderly patients anyway, who have chronic C. difficile infection. And C. difficile infection can prove fatal. And we know that with 90% certainty, an FMT, or a fecal microbiota transplant, can be effective. Now, James Parkinson was the first, obviously, to describe what we now refer to eponymously as Parkinson's disease. And there has been increasing evidence over the past decade that the gut microbiota might be involved in the pathophysiology of Parkinson's disease. We know, for instance, or from epidemiological studies that individuals who would have had a full truncal vagotomy, now people haven't been doing full truncal vagotomy since the 60s or early 70s, but that people who had a full truncal vagotomy in the 60s or early 70s, that they have less Parkinson's disease. Now, there's other evidence as well, to suggest that Parkinson's disease might be connected with the gut microbiota. But this is a preliminary study of a fecal microbiota transplant. It was published in Medicine about 18 months ago. And it's a small study and it's a preliminary study. But what it shows, if you look at the lower graphs there, you see that on the neurological side of things, that some patients showed an improvement in neurological symptoms. Now, there were others who didn't, but there were some patients who definitely showed an improvement in neurological symptoms when they had a fecal microbiota transplant. Psychological symptoms, as many people will know, depression is incredibly common in Parkinson's disease. At any point in time, 30 to 40% of patients with Parkinson's disease are clinically depressed. And what you can see is that the fecal microbiota transplant, if you look at the Hamilton Depression Scale, which is on the top thing there, the HAM-D, that showed an improvement in many of the subjects. So what we have here, look, one has to be cautious with any study like this. It's an open study of FMT, but it suggests that FMT might benefit some patients who have Parkinson's disease. Now, this is a more recent study, and it's a placebo-controlled study of lactobacilli strains over a 12-week period in patients with Parkinson's disease. Now, it's randomized, it's double-blind, placebo-controlled. There are some elements about the study I'd like to certainly know more about, but what it does suggest is that in contrast to placebo, the probiotic intervention did benefit many of the subjects who had Parkinson's disease. So it raises the question that certain probiotic interventions might benefit patients with Parkinson's disease. Now, we introduced the concept of a psychobiotic in 2013 or whenever, and we defined it as a bacteria which, when ingested in adequate amounts, has a positive mental health benefit. And it's a concept that has caught on in the literature. You'll find many people using the term. And with the textbook there, well, it's not a textbook, it's a book for the lay public called The Psychobiotics Revolution, is a book we have out with National Geographic, just describing what psychobiotics are and how they actually work. So are there bacteria out there that can really benefit people with mental health problems? And that's what I want to try to answer now, because I do believe that they are. I won't go into this study in a lot of detail, but suffice it to say that in this study, which was in mice, we found that when we gave a strain of biflongum, that it seemed to reduce anxiety levels, and not only that, but that the cognitive functioning of the animals improved when they were on the biflongum. So biflongum seemed to have a useful benefit in mice. But look, I've seen studies, and I'm sure many of you have, in mice, and they didn't translate into humans. So the question is, was this of any benefit in humans? So in this study, it's a placebo-controlled crossover design study. And what we essentially did was we used biflongum and we used placebo, and we were interested in looking at a number of variables. The first variable we were interested in looking at is the output of saliva in the output of cortisol in saliva in the morning, because that's one of the best indicators of stress. If you're stressed, when you wake in the morning, your levels of cortisol in the saliva tend to be elevated. So what we found is that biflongum, in contrast to placebo, reduced salivary cortisol levels in the morning. Not only that, when the subjects were on biflongum, as opposed to placebo, they perceived themselves as less stressed. So we had here a relationship between a reduction in cortisol levels and the feeling of individuals that they were less stressed. Now, interestingly enough, also, we found that we actually found electrophysiological evidence. I think it's one of the few studies, it might be the only one, in fact, in the literature. We found that electrophysiologically, when we measured the EEG activity in the brain, it was altered following the ingestion of the probiotic. Now, we also found some cognitive functions improved using the CANTAB. For instance, paired associate learning was one parameter that we found improved when subjects took the biflongum. This is another study. There's been a lot of noise in the literature of late, or a lot of publications, suggesting that certain probiotics could improve sleep. And this was a study we did in students where we looked at them over 2 semesters. And in one semester, we treated them with either a biflongum or a probiotic, or a placebo. And in the next semester before their exam, we treated them with the alternate treatment. So they got a biflongum one semester, they got placebo the other. And we followed them through their exam, and we were interested in looking particularly at sleep. And what we found was that the sleep duration was longer, was greater in those who were given the biflongum. So during the stress of an exam, sleep duration was improved with biflongum. Now, this seems to be consistent with 2 or 3 other studies in the literature that have also come out fairly recently. This particular study, this is a study of a Lactobacillus rhamnosus. And now, Lactobacillus rhamnosus is a probiotic strain, and I think that this is a very nice study. It's not the study I was connected with, but I do like it as a study, because depression during pregnancy and depression in the postpartum period are obviously very common. A lot of women experience depressive symptoms during pregnancy and postnatally. So this is a study of a very large cohort. There were 423 women. Now, the primary outcome measure here was eczema in children, but from the beginning, they planned to look at depressive symptoms in the mothers. So from the 2nd trimester of pregnancy, the women were either treated with the Lactobacillus rhamnosus or a probiotic. And they continued to take this for a number of weeks postnatally. So the question was, can this probiotic alter the depressive symptoms during pregnancy and postnatally? So that was the big question. And what they found essentially was the Edinburgh questionnaire is the most, I suppose, significantly validated questionnaire for looking at depressive symptoms postnatally and anxiety symptoms as well. And what they found was that treatment with the Lactobacillus rhamnosus reduced the prevalence of depressive and anxiety symptoms postpartum. Now, I think that's a very, very important observation. It needs to be replicated by another group, but I think it really is an important finding, because this is one nasty depressive syndrome that is common and afflicts women at a time in their lives where they should be happy, a new baby or whatever. And this particular intervention does seem to be effective. So what is the current state of play in relation to probiotics and depression? Well, there have been a number of meta-analyses done. This meta-analysis was published in December, I think, of 2019 in Psychiatry Research. And it comes to the conclusion that depression reducing effects of probiotics are significant in those with major depression. So that if somebody is clinically depressed, they conclude that certain probiotics do work. They don't say that antidepressants have any effect in the general population in terms of depression, but if you're not depressed, it's not very relevant. I mean, probiotics could have other benefits and if you're physically healthy, but if you're not depressed, it's not surprising they're not going to lift your mood further. And they conclude, now I have certain reservations about this, but the conclusion they come to is that multiple strains are more effective than single strains in treating depression. But anyway, overall, they come to the conclusion in this meta-analysis that probiotics are indeed effective in treating depressive illness. Now, prebiotics are largely fibers which promote the growth of good bacteria. Now, I say are largely because I think we've tended to define prebiotics in too narrow a way. You see here some of the food substances which are high in inulin, which is a prebiotic, for example, Jerusalem artichoke and leeks and onions and so forth. But I think it's now clear that there are other substances out there that are prebiotic that are not necessarily fibers like inulin. For instance, we showed that polyunsaturated fatty acids like EPA, which you get from fish, has a significant benefit in terms of increasing the numbers of bifidobacteria. It's also true that certain polyphenols like curcumin and xanthohumol can also increase the levels of good bacteria. So I think our traditional view of a prebiotic is expanded. So it's not just fibers now, you have polyphenols as well and polyunsaturated fatty acids. Now, do prebiotics have any impact in terms of mental well-being or stress response? Well, on the left-hand side of your screen there, you see a study that we published 3 or 4 years ago, looking at the impact of FOS and GOS, which are 2 prebiotics, on the most widely used tests for detecting antidepressant activity in rodents. That's the tail suspension test and the force swim test. And what you can see is that the combination of FOS and GOS comes out and passes the antidepressant test, at least in terms of these 2 tests. And they are the 2 of the most widely used tests in the pharmaceutical industry. On the right-hand side of your screen, you see a study from the group in Oxford, Phil Burnett's group, showing that a modified version of GOS, BGOS, is capable of reducing the morning salivary cortisol level. So the main stress hormone is reduced when subjects are taking BGOS, and this is a placebo-controlled study. It's a nice study from Phil Burnett's group. Now, we recently published a study with a complex sugar, and we essentially found some improvement in certain cognitive tasks when the subjects were taking this prebiotic. So I think there is increasing evidence that you can have an impact on mental health by using prebiotics that stimulate the growth of good bacteria. Of course, obviously taking a probiotic might have a more direct impact, but I think both strategies can obviously be beneficial. Now, this is a summary of a European consensus document that we put together 3 or 4 years ago, giving advice in relation to the nutritional management of depression and suggesting that really, patients who are depressed should optimally be on a Mediterranean type diet, that there should be plenty of fruit and vegetables, they should be fermented foods, preferably fish, grains, nuts as well are obviously beneficial, and that red meat should probably be kept to a relative minimum. When you look at the impact of I suppose, what I would describe as a classic Western diet, which you tend to see more in Northern Europe, I suppose, than you do in sunny Italy or Spain, you find that a classic Western diet that has a lot of processed food tends to result in a dysbiosis, an alteration of the gut microbiota, a negative alteration of the gut microbiota. And that a more classic Mediterranean diet is associated with a much healthier gut. And of course, if you've got dysbiosis, if you see a dysbiosis of the gut microbiota, that leads to inflammation. And of course, we know that inflammation leads to a raft of diseases. So I think, a bad diet leads to dysbiosis, which in turn leads to inflammation and all the consequences that emanate as a result of an inflammation. Now, this is a study from Felisa Jacka in Deakin University in Australia, where she took a group of depressed patients and she measured their symptoms using the MADRS scale. And this is just the results, the summary of her results. Half the subjects they were all depressed, and half of them were randomly allocated to receive social support and half of them to receive a dietary intervention, which was going on a modified Mediterranean diet. And what you can see is when they went on a modified Mediterranean diet, they had a far greater drop in depressive symptoms than they had when they had a social intervention. Now, to be honest, I'm always skeptical about case vignettes because, heck, they're no substitute for a proper controlled trial. So I'm going to give you this history here, and I put it across with a health warning because it is only one case, but I could give others as well. This was a 44-year-old married lady who was referred to my clinic. She had 2 teenage children, and she was referred to my clinic. My clinic, I tend to treat people who have resistant depression. And this woman had a 12-month history of depression. Now, she had a previous episode which occurred following the birth of her first child. Now, when she came to me, she was clearly depressed. There was no obvious, clear-cut psychosocial precipitant from her depression. She didn't have a family history. Her marriage was a happy one. There were no financial problems in the family. She came from a fairly middle-class kind of background. Now, she had underwent a course of cognitive behavior therapy with a very good psychologist I know, and he's incredibly good, and I know that she had a full course of CBT, and it didn't work. Then she was prescribed in quick succession escitalopram and venlafaxine. Now, I saw her, and amongst, what I essentially did, given the fact that she had failed 2 antidepressants and a course of CBT, I put her on a graded exercise program. She certainly wasn't getting any exercise when she saw me. I put her on a course of lactobacillus rhamnosus. And over a number of weeks, there was a massive improvement in her mental state, which I genuinely believe was due to the change in her behavior, i.e. the exercise, and the probiotic. And 6 months subsequently, she remains entirely well. So just in summary, ladies and gentlemen, I think that gut microbes are essential for normal brain function. I think the gut microbiota is dysregulated in a variety of conditions, including depression and Parkinson's disease. I think that psychobiotics have potential in managing stress-related disorders. And, I think that at the end of the day, of course, one cannot outrule the importance of diet in managing conditions like this as well. Thank you very much for your attention.
Okay, thank you very much, Ted, for your very nice presentation. I'm collecting some questions for you from the chat. Did you hear me? Yes? Okay. Yes. So the first question for you is, okay, the first question is, based on what you said, do you think that modern psychiatry should look at the microbiota as an integral part of the therapeutical approach in the treatment of psychiatric patients?
I think that is a very valid point, and I think there's more and more evidence emerging to suggest that should be the case. if you take even medications that we use, olanzapine, we all use olanzapine for treating schizophrenia and so forth. We've published a series of papers showing that olanzapine, which obviously causes weight gain, has a massive impact on the gut microbiota. So I do think that the state of the gut microbiota is very relevant in relation to treating psychiatric illness. And it's also worth pointing out that, of course, our first antidepressants were actually antibiotics. I mean, the first antidepressant registered in Europe was an anti-tuberculous drug. So, we started off with antibiotics as antidepressants. And of course, we're now coming around to the view that maybe the microbiota is indeed relevant.
Okay, thank you. Another question from a neuroscientist like me to you, another neuroscientist. So, in the past 2 years, was there an increase in number of clinical studies facing the microbiota gut-brain axis? In particular, what about the clinical studies on depressed patients? So I'm thinking about randomized placebo-controlled trials with good statistical power. So what do you think about in the last 2 years?
Over the last 2 years, I think there have been some, but I do think that, we need bigger studies. Bigger, better studies. One of the limitations of this area is that we have lots of positive studies. Of course, as so often in science, the negative studies aren't published. I mean, because the journals are less likely to take them. And I do think that we do need bigger placebo-controlled trials. So I think that yes, we're seeing more studies being done, and it's good to see more companies involved in this area. But I do think that we need the bigger placebo-controlled parallel group design studies.
Okay. The last question from the chat. So, why are you suggesting the use of psychobiotics after the first 3 months of pregnancy and not from the beginning of pregnancy?
Oh, indeed. I think that it might be very worthwhile taking the pregnancy. That was just the way the study was designed. But I could see no reason, Probiotics are not going to do the baby any harm, that's for sure, and they won't do the mum any harm. So I could see no reason for not taking it in the first trimester of pregnancy. I agree entirely. It was just the way that study was designed.
Okay, thank you very much.
Thank you. Cheers.
So I think that we can go on with the last speaker. The last speaker is Professor Giovanni Barbara. Okay. Hi, Giovanni.
Hi, Paola.
So he's professor of gastroenterology at the University of Bologna, at the Department of Medical and Surgical Sciences, Sant'Orsola Malpighi Hospital of Bologna. He was the past president of the European Society of Neurogastroenterology and Motility, ESNM. And it's really difficult to summarize the CV of Professor Giovanni Barbara with more than 300 international publications and more than 200 papers peer-reviewed with impact factor based on gastroenterology topics. So I'm really pleased to introduce you. And you will talk about the functional gastrointestinal disorder or disorder of gut-brain interaction. Please. You can share your screen.
Thank you very much, Paola, for this very kind introduction. It's a real pleasure for me to be here today. And what I'm going to talk about is functional gastrointestinal disorders. And as you will see from this presentation, you will appreciate that the way we now classify and define these disorders is a little bit different. So the definition is now that of disorders of gut-brain interaction. And during the presentation, we will see why we now define these disorders in a different way. So if we look at the general population, we realize that gastrointestinal symptoms are very common, and these can be detected in up to 60% of the population. And these can be related to the upper gastrointestinal tract, such as heartburn, early satiety, nausea, or the lower gastrointestinal tract, such as abdominal pain, bloating, constipation, and diarrhea. So the paradigm here is that if you are symptom-free, probably you are in the minority, and these symptoms definitely are very, very common. If you look at the data that are coming from the United States, this is a paper that was published some years ago, you will see that the outpatients that are coming into the clinic in the United States complain of these 6 symptoms mainly: abdominal pain, diarrhea, constipation, vomiting, nausea, heartburn, and indigestion. Then we have a constellation of other symptoms that are less common. But if we consider the first 6, then we realize that in most cases, these patients complain of functional gastrointestinal disorders, such as disorders that are not related to organic causes that can be detected with endoscopy, ultrasounds, CT scans, and so on. So these are the so-called functional gastrointestinal disorders that can affect the entire gastrointestinal tract from the esophagus down to the anorectal region. And you can appreciate that some of these symptoms are very common, such as functional heartburn, functional dyspepsia, irritable bowel syndrome or IBS, functional constipation, bloating, diarrhea, and so on. So this study that I present here is a very recent study that is basically a survey that was carried out in a very large sample of individuals in 26 countries. And what this study tells us is that at least one functional gastrointestinal disorder is present in 40% of the general population worldwide. So these functional gastrointestinal disorders are definitely very, very common. And we need to consider these symptoms as gastroenterologists, but not only as specialists, but also in general practice and also in other specialist practices. So if it is quite easy to understand why a patient with an organic disease, such as, for example, active ulcerative colitis, can complain of symptoms such as abdominal pain, rectal bleeding, and diarrhea, for example, it is less easy to understand why a patient that is in a quiescent phase of active ulcerative colitis, or a patient that had a previous episode of gastrointestinal infection, still complain of symptoms in the long term. It is even less understandable why a patient that has an unremarkable colonoscopy, ultrasound, CT scan, and other tests negative, why they complain of abdominal pain and changes in bowel habit. So for this reason and many other reasons, these functional, so-called functional patients are people that are not well understood by doctors, and the term functional is often improperly used to indicate an idiopathic or cryptogenetic condition. And patients, unfortunately, are labeled as neurotic, apprehensive, otherwise healthy people with an imaginary disease in their head and nothing wrong with their bowels. So the reason why we now try to redefine these symptoms in a different way is because beside the changes in the brain, anxiety, depression, which are definitely present in these patients, there are also changes in the gut. And so these disorders are now called disorders of gut-brain interaction, an exchange of information between the gut and the brain and the gut. And in the periphery, that is in the gastrointestinal tract, there are a number of different changes in the physiology that we can now detect and define in these patients, such as motility disturbances, visceral hypersensitivity, changes in the immune system, changes in the gut microbiota, as we have heard before in the beautiful lecture of Ted Dinan, and also a change and a modification in the processing of stimuli that travel from the gut to the brain and back from the brain to the gut. Here are some examples. I will not go into details, but just to tell you that if we think, for example, functional esophageal disorders, most people that complain symptoms in this category don't have erosive esophagitis, don't have ulcers, don't have macroscopic changes that can be detected with endoscopy, for example. Most of them have hypersensitivity or functional heartburn. So there is no evidence, if we do tests, that there is something wrong with their esophagus. Similarly, changes can occur in the gallbladder, and many patients without gallbladder stones complain of symptoms that originate from the gallbladder or from a change in the motility of the sphincter of Oddi. Another example is dyspepsia. If we do endoscopy in dyspeptic patients, then we will find out that up to 70% of these patients have functional, so-called functional dyspepsia, so no evidence whatsoever of organic changes underlying the symptoms. If we move down into the bowel, then we have the functional bowel disorders. And this is a very large category of functional disorders that is more a spectrum of disorders rather than separate entities. And the two main domains of functional bowel disorders are the Bristol stool scale that we use to classify the type of defecation, the form of stools. For example, if you see up here, we see type 1 that is more common and type 2 more common in functional constipation, and type 6 and type 7, which are more common in diarrhea. If on top of this, we add the domain pain as we go down in this scheme, then if we have pain, together with the changes in bowel habit, then we will develop IBS, which can be with constipation or with diarrhea or in the mixed form if the patients alternate between constipation and diarrhea. So from now on, I will use IBS as a paradigm to explain functional gastrointestinal disorders. Why do I choose this particular form of functional gastrointestinal disorder? First of all, because this is my first love, and I have done some studies in this syndrome, and also because this is probably the most complex form and less understood form of functional gastrointestinal disorder. And last but not least, because the prevalence of IBS is probably the highest among different gastrointestinal disorders. Here you can see the worldwide prevalence of IBS, and you see that ranges between 5 and 30%. I would say that the average is around 1 person in 10 in the general population suffering from IBS. The prevalence is very high in the younger ages, around 30 to 40 years, and then it tends to decrease over time. And why young adults suffer from this syndrome? Maybe because there are several factors that influence the perception of symptoms in the youngers. They move out from home and they change diet, they start a new job, they start and end relationships. So this is a period when there are several changes and several stressors that may influence the perception of symptoms. Another factor that we have to consider in IBS and in many other functional gastrointestinal disorders is that there is a high prevalence, and this is quite common, as you see in this meta-analysis in most studies that have studied the prevalence according to gender, is more prevalent in females according to these studies. You can see also that there are studies that suggest that the prevalence is not so high in females, and even in some countries is more prevalent in males. And the interpretation of this controversy is probably related to the fact that there are also some cultural factors that lead to the females to go to the doctor in certain countries, particularly in Eastern countries, while in Western countries, while in Eastern countries, probably for some factors, males go more to the doctor, and this may reflect these changes in the prevalence in males. Another factor that is probably important to understand why females have more symptoms than males in functional gastrointestinal disorders is that sexual hormones are probably important in the development of symptoms, and probably the menstrual cycle is also another factor that aggravates, as you can see in this old but still valid study, aggravates symptoms in females as compared to males. There is another probably important explanation of this is that sex hormones are also important in several physiological functions like sensitivity, secretion, permeability, and other factors like the immune system. For example, certain immune cells, such as mast cells, are more reactive to certain sex hormones. And also sex hormones may modulate in a way the gut microbiota, which is important, as we heard before, in the physiology of the gut and symptom generation. There are other factors that need to be considered in the pathophysiology and in the etiology of IBS, particularly perinatal and familial risk factors that are listed in this table. You see that, for example, a birth weight which is below 2,500 grams is a risk factor. Being a son or a daughter of a divorced or a widowed mother is another risk factor. So there are perinatal factors that we need to consider. And among these factors, probably also the microbiota and how the microbiota develops during the perinatal period, having, for example, a cesarean rather than natural type of birth is another risk factor. Lactation is another factor. Another important aspect is that these symptoms don't stay stable over time. They tend to wax and wane. And if we look at this table, which is rather complex, just concentrate on the last column here on the right in green, you will see that if we classify a patient with a particular form of functional gastrointestinal disorder, we will see that after 12 years, a large proportion of the patients don't have symptoms anymore. For example, 30% in IBS and 62% if they have constipation and diarrhea, so the mixed form. So symptoms fluctuate over time. An important factor is that these symptoms, particularly abdominal pain, but also changes in bowel habit, have a severe impact on the quality of life of the patients. Here you can see the different domains on the bottom of the slide, physical domains as well as psychological domains, and the blue line is the general population. If we consider IBS, for most of the domains, both physical and psychological, the quality of life is significantly impaired. But if we look, for example, at an organic disease, which is in our mind well related to a poor quality of life, such as IBD, for example, we will see that the quality of life of IBD patients are very similar to that of functional gastrointestinal disorders and IBS in particular. And more importantly, if we look, for example, to heart failure, which is in our mind a very important and severe disease, apart from certain physical domains, most of the psychological domains are very similar to those of IBS. So this generates a huge burden of functional gastrointestinal disorders and IBS in particular, in terms of quality of life for the patients, costs for the patients, because we have to realize that most of the medications are not supported by any government. So the patients has to pay out of the pocket the costs of the medications. And then we have also other important items here. And as a matter of fact, if you look on the top right-hand side of this slide, a very old survey, but I think still valid, tells us that the patients would sacrifice 10 to 15 years of their life for an immediate cure of their disease. So this tells us a lot about the impaired quality of life of the patients. So the symptoms in IBS are not only gastrointestinal symptoms. We have to consider that many of these patients also complain of systemic symptoms, such as rheumatological symptoms, neurological symptoms, urogenital symptoms. First, let me tell you another concept that is very important. The concept that functional gastrointestinal disorders often overlap, and if a patient has IBS, it is very likely that has also dyspepsia and also gastroesophageal reflux disease. This is because the gastrointestinal tract that we try to divide in different anatomical regions has a common origin and has a very similar way it is composed. The mucosa, the submucosa, the enteric nervous system, the immune system. So if it is true that there is something wrong in one of these components, it is likely that most of the gastrointestinal tract is affected. So this explains the overlap between the upper and lower gastrointestinal symptoms. What are the chief symptoms of IBS? Well, the first important symptom that we have to recognize that is mandatory for the definition of IBS is abdominal pain. Without abdominal pain, we cannot diagnose IBS. Then we see that abdominal bloating is also very, very common. And then we have the other symptoms. What about abdominal bloating? Abdominal bloating probably needs to be separated from abdominal distension. Why is that? Abdominal bloating is a subjective sensation of abdominal inflation, a sensation, while abdominal distension is an objective and measurable increase in abdominal girth. Why we tend to separate these two conditions? Because the pathophysiology is likely different in the two conditions. And also the therapy, according to certain trials, could be also different in the two conditions. The Bristol stool scale that I presented to you before is very important, and I use it every day in my clinical practice because patients quite often don't tell you exactly what is diarrhea or constipation. If you ask the patient what is diarrhea, then they tell you, yes, I have diarrhea, but I have Bristol stool scale 1 and 2, so that is not diarrhea. So showing an objective and measurable way of depicting the way they go to the toilet is very important. And according to this Bristol stool scale, then if type 1 and 2 are present in more than 25% of their bowel movements, then we classify IBS with constipation. If we have Bristol stool scale type 6 and 7 with diarrhea, and if we have alternation between the two, we have IBS with mixed type of bowel habit. Why is important to use these scales? Because these scales tell us a lot about the physiology of the gut. If you look at this graph, you will see that there is a very nice linear correlation between the type of the Bristol stool scale and the colonic transit time. So having Bristol stool scale 1 and 2 means that there is a very slow colonic transit, while having 6 and 7 means having a fast transit. Even if this is not the rule, and some patients have normal, and probably a vast majority of the patients have a normal transit time. Another couple of important symptoms that worry a lot the patients are, first of all, urgency. And you can see from this study that urgency is very common, and also is more common as expected in patients that have IBS with diarrhea and IBS with mixed type, while it's very uncommon in patients with IBS with constipation. Second, and very important symptom that probably is not detected in a large proportion of patients because of certain unwillingness of the patient to tell us about this symptom is fecal incontinence, which according to this study published recently in Neurogastroenterology and Motility is very common in patients with diarrhea, and up to 17%, so a large proportion of the IBS patient is present in this syndrome. What about systemic symptoms? Systemic symptoms are very, very common. And probably this tells us another thing, that there are changes that are systemic in the patient. For example, the immune system, the nervous system, and other changes, and the microbiota, for example, because the microbiota, as we heard, has several systemic effects that can affect the entire body of the patient. So if we have dysbiosis, changes in gut microbiota, then we can get systemic symptoms. So the pathophysiology of these syndromes may be common, and the picture is very complex, because I often show to the microbiologist that always show very difficult graphs showing the complexity of the microbiota. I can tell you that the complexity of the clinical pictures in this patient is as well complicated. You see that the IBS patient often complains of migraine, dyspareunia, interstitial cystitis, fibromyalgia. And on the left side of the graph of the slide, you see the overlap between the symptoms in the different tract of the gastrointestinal system: reflux plus diarrhea plus constipation or dyspepsia and IBS. So a very complex patient when we see them. And this complexity probably tells us why the patients often are not managed in a good manner. And particularly worrying is the fact that in certain instances, some of the symptoms complained by the patients, and if we look at the different locations of abdominal pain, can be misdiagnosed with other potential causes of symptoms. And for example, if we have pain in the left abdominal fossa, for example, here, We have the uterus. Sorry, this slide is in Italian, but I think you can understand quite well anyway. In the upper gastrointestinal tract, we have the stomach, but also the pancreas, the gallbladder, the appendix. And this explains why, if these patients are misdiagnosed, the surgical procedure, according to the literature, this is nothing I'm saying, is something that is taken by the literature. The surgical procedures in IBS patients are increased by 3 times in comparison to the normal population. And probably most of these surgical procedures were avoidable. And most of these surgical procedures worsened the symptoms rather than curing the symptoms. Rheumatological comorbidity, fibromyalgia, very common in IBS patients. You see here the graph, 31.6% versus 4.2% in the general population. Interstitial cystitis, very common. And this is an unpleasant sensation of having the stimulus to urinate, even if there is no need to urinate. And interestingly enough, if we take biopsies in the bladder, the morphology is very similar to what we see in the colon. Mastocytosis, overgrowth of neuronal fibers of the bladder, and other changes that are common in patients with IBS. Also gynecological problems, dyspareunia. This affects around 10% of fertile women, but up to 1/3 of patients with dyspareunia have also IBS. So the link is very, very strict. What about psychological comorbidity? Psychological comorbidity is very common, and for this reason, probably is why people think that this is a psychiatric or a psychological problem. Nothing wrong in the bowel of these patients, so she must be neurotic. Maybe this lady has problem with her husband. She is stressed for her work. She has a newborn baby and she's very stressed, and she has to work as well. So that's why she complains of symptoms. The link between stress and the bowel has been known for decades. This is a very old study published in 1949, so many, many years ago. And this particular experiment that probably is not ethical anymore, or very, very certainly is not ethical anymore. This is a patient with a condition that was called at that time spastic colitis. These doctors were doing a colonoscopy to these patients, and at the same time were recording motility in the colon. And at a certain time, the doctors told the patients, unfortunately, you have cancer. We are very afraid about that, and we will finish colonoscopy and we will let you go. And at the same time, when they said that to the patient, the motility index went on the top, and there were spasms, and the patient was sweating and was very nervous, obviously. And then they told the patients, okay, it was a joke. Nothing is wrong with your gut. And the motility index went down to normal. So this tells a lot about the effects of stress on the bowel and the connection between the brain and the gut. And certainly, if we look at the literature, we see that patients with IBS have more anxiety, more depression compared to the general population, and also compared to organic GI disease. However, most of these studies were carried out in tertiary centers where the prevalence of these psychiatric symptoms is very high. And if we go into the general population, on the other hand, we see that this difference is very small, still significant, but paranoid ideation, hostility, anxiety, depression is there in patients with IBS compared to controls, but is not that big. So what is the current view of the role of psychological disorders in IBS? Is that this is very prevalent in patients that go to referral centers, less prevalent in general practice or in the general population that does not consult the doctor. So probably the presence of psychological disorders brings the patient to consult the doctor because they are worried, for example, that they have a serious disease, cancer or other serious diseases. So the view of IBS that everything is in the mind of the patients and nothing is wrong with the bowel of these patients is an old one. And I'm very much convinced that there is this certainly this link between the brain and the gut, but patients also have several problems in their gut. And so this explains why the view on the pathophysiology of IBS has changed over the years. First, stress, and then up to now, the changes in the gut, including the changes in the microbiota, food, and also the mucosal immune system. And I will show you a few examples of this new literature. There are several factors that have been discovered over the years, including those that Dinan has shown in the microbiota of these patients. But let me start from the origins and first studies that showed that there is something wrong in the bowel of these patients. First of all, it was the case for motility. Everybody was thinking that IBS was a disorder of gastrointestinal motility, first colonic motility and then intestinal, small intestinal motility. And these are manometric tracings that were showing that there were these contractions called cluster contractions that were more common in patients with IBS compared to healthy controls. And at the beginning, they thought, the people that were doing research in this field, they thought that these were pathognomonic of the disease and they were a biomarker of the disease. Then they discovered that these changes can be present also in other disorders and were not so specific for IBS. So research moved to other fields. And the next field that came out in the literature was visceral hypersensitivity. Visceral hypersensitivity is common to functional gastrointestinal disorder, not only to IBS, and can be easily reproduced in the laboratory if we stimulate the gut, for example, mechanically by inflating a balloon in the rectum, for example. Then we would ask to the patient the sensation that they feel, sensation, discomfort, pain, and with the scale that was is going up until very, very bad pain. And according to this, the threshold for perceiving these stimuli is reduced in patients with IBS and also in patients with other functional gastrointestinal disorders, such as non-cardiac chest pain, functional dyspepsia, and here you can see on the right IBS. However, only a proportion of the patients have this visceral hypersensitivity. So visceral hypersensitivity, as well as changes in motility, do not explain entirely the symptoms perceived by the patients. There are other triggers of symptoms of IBS, and apart from stress, depression, and anxiety, we talked about this, there is also food, medications, infections, menses, and early life events. What about infections? This has been, I would say, something that changed the way we think about functional gastrointestinal disorders. This sir is Sir Arthur Hurst. He's the founder of the British Society of Gastroenterology, and he described this syndrome, persistent intestinal irritability after acute dysentery in soldiers that were returning back from war campaigns in regions that were endemic for bacillary diarrhea. It turned this condition as post-dysenteric colonic irritability, a condition that we today call post-infection IBS. And this tells us a lot about the organic nature and not the psychological nature of functional gastrointestinal disorders. And if you see at this meta-analysis, if you get an infection that is particularly severe, related to Campylobacter, Shigella, Salmonella, but also viral gastroenteritis, as well as parasite gastroenteritis, then you increase the risk of developing a functional gastrointestinal disorder, such as functional dyspepsia or IBS, in around 10% of the patients that were involved in this episode or bout of gastroenteritis. So this scheme that you see here is basically the new dogma, I would say, of functional gastrointestinal disorders, where we have luminal factors, food, the microbiota, bile acids, the epithelium, which is very important, that is probably changed in a way that permits the passage in excess of substances coming from the lumen down into the mucosa and stimulate the abnormal responses there, particularly in the immune system, that then releases substances such as cytokines, prostaglandins, histamines from mast cells that communicate to the nerves. On one hand, on the enteric nerves that modulate motility and secretion, and on the other hand, stimulating the activation of sensory fibers that convey information to the central nervous system, developing then symptoms such as abdominal pain, for example. Another important factor is the lumen and the microbiota. And this paradigm of the FODMAP is very common in the literature now. If we eat certain foods that contain carbohydrates that are poorly absorbed from the small bowel, these carbohydrates then can arrive in excess in the lumen of the colon. And in the presence of a change in the microbiota, particularly an overgrowth of certain bacteria that fermentate certain carbohydrates, then you can have a production of hydrogen gases, methane, and other substances that can induce visceral hypersensitivity, diarrhea, and symptoms, and so on. I think that there are certain scenarios that link the microbiota to IBS. First scenario, we mentioned it already, is post-infection IBS. But also if we consider, for example, patients that take, or subjects that take antibiotics, and these antibiotics generate dysbiosis, they are at higher risk of developing IBS. On the other hand, if we modulate in a good way the microbiota with the probiotics, non-absorbable antibiotics, or diet, then we can get a symptom improvement. And this links the microbiota clearly to the phenotype of IBS. Other data suggest that the microbiota of IBS is different as compared to healthy control subjects, but also different from a patient with other diseases, such as, for example, inflammatory bowel disease, Crohn's disease, and ulcerative colitis. And according to this very large study, almost 1,800 individuals with IBD and IBS, then if we characterize very well the characteristics of the microbiota, as well as the function of the microbiota with metabolomics, then we can obtain a fingerprint, a biomarker that can differentiate very well IBD from IBS from healthy controls. Is this an epiphenomenon, or is this important for symptoms? Probably is important for symptoms if we look at this data. A reduced microbiota richness, which is an indicator of unhealthy type of microbiota, then this reduced microbiota richness is strictly related to the severity of the symptoms perceived by the patients. All the interaction between the microbiota and the body of these patients is within a very thin layer of epithelial cells that separate this microbiological environment from the inner body. And we have the mucous barrier, the epithelial barrier, and also a vascular barrier, which is underneath the epithelial barrier, and everything that passes through the epithelial barrier has to cross also the vascular barrier in order to gain systemic access. So we have to consider this interface, which is very important. So permeability and the mucosal barriers are very important in controlling this very delicate equilibrium between the microbiota and the host. Epithelial barrier, there are several studies that have investigated the epithelial barrier in patients with IBS. This is one of these. Look at the electron microscopy. Just look at these distances between the epithelial cells in a patient with IBS with diarrhea. And look at the normal control. The normal control, the two epithelial cells are touching one another. In the IBS patients, there is a large space that allows the passage of substances in excess down into the mucosa. Also, there is this arrangement of the tight junctions that are placed there to control the passage of substances from the lumen down to the mucosa. And these changes were very nicely correlated both with diarrhea and with the intensity of abdominal pain. Another aspect that is, I would say, my first love is the immune system in the gut of patients with IBS. So this is a very old study, 2004, and we were taking at that time biopsies from healthy controls on the left and IBS patients on the right. The red dots indicate the mast cells in the mucosa. The green staining are the nerves that control motility as well as sensory perception from the gut to the brain. And if we look more carefully at the interaction between mast cells and the nerves, you see on the right in the electron microscopy that we see often the mast cells that are degranulating very closely to a nerve. And this nerve has all the receptors for all the substances that are released by the mast cell, including histamine, prostaglandin, proteases, cytokines, and so on. So this mast cell is affecting the firing, the activation of this nerve fiber that probably is conveying information up to the brain. And most importantly, the presence of mast cells close to the nerves was correlated in a linear fashion with the severity and frequency of abdominal pain in patients with IBS. So now, just to finish, I would like to show you a few slides regarding on what we do with this patient. We have to make a very firm, I would say, diagnosis, and probably this can be done according to the symptoms at our first visit, just using our mind, our hands, taking a good history, and making just a few very basic further laboratory exams, such as PCR or other exams, a complete blood count, and other few tests. And then we can make a diagnosis. And I will not get into details in this very complex algorithm, but it's important to, first of all, exclude alarm features, unintentional weight loss, anemia, a palpable abdominal mass, rectal bleeding, and so on. And then do the very short CRP and complete blood count and other few things. Exclude probably celiac disease. I will come back to this shortly. And then when we make the diagnosis, then at this point we have to classify the patients according to the phenotype in the different types of bowel habit, and then start treatment. So the positive diagnosis of IBS can be made with just 4 key features: clinical history, physical examination, minimal laboratory tests, and colonoscopy or other appropriate tests only when clinically indicated. Unfortunately, what we see is this in our practice. It's 4 colonoscopies, 4 ultrasounds, 4 CT scans, and the patients arrive to our office with a huge pile of exams that they have done, because on one hand, the doctors maybe are worried to miss a serious disease. On the other hand, is the patients that is requiring to do more exams because they are not satisfied with the diagnosis of IBS. So this slide shows you that basically there is a huge amount of tests that doctors do, and in most cases we don't find much with this. Colonoscopy, some doctors think that if we do a colonoscopy to our patient, then we reassure them that everything is fine and IBS disappears. This is not the case, and has been demonstrated in the literature. If we do colonoscopy, which is not indicated for other reasons, then it is unlikely that colonoscopy can pick other diseases such as adenomas or colorectal adenocarcinoma and so on. There are a few exceptions to this. If the patient goes to academic medicine and there is a reason to do further testings, this could be for research reasons, or maybe because in that particular academic center there are changes that can be detected with particular examinations, and this could lead eventually to a different approach, therapeutic approach. The other 2 last examples that I think that the doctors need to keep in mind when approaching patients with IBS are, first of all, celiac disease. In regions where celiac disease is very prevalent, more than 1%, then it is worth looking at least at serology for celiac disease. Second condition is macroscopic colitis. This is in patients that have IBS with diarrhea and have symptoms that are very refractory to the common therapies, particularly in females and particularly in the elderly. So apart from these cases, in general practice, not in academic medicine, but in general practice, we should stop and start treating the patients. How do we treat them? This is another story. Probably we would need an entire webinar to talk about IBS management, but dietary and lifestyle advice, maybe probiotics, maybe changes in diet, and then phenotype the patients, and then treat the different symptoms with all the different medications that we have available for these patients. So with this, I will end by telling you that this is not a trivial disease. This is not a disease in the mind of the patients. These patients are not crazy. These patients are patients that suffer a lot, and they have a change in the way the brain communicates to the gut, and the gut communicates with the brain. And we have to believe when they say that they suffer and find the best diagnosis and the best treatment to improve their lives. Thank you very much for your attention.
Thank you very much, Giovanni, for your beautiful lecture. Remembering us that physiology is more and more an integrated science. Until 10 years ago, it was quite impossible to talk about the mutual brain-gut microbiota that interact top-down and bottom-up in a bidirectional way. Thank also for this new view of IBS as a functional gastrointestinal disorders, and with the description of extraintestinal symptoms that are so many and really important. So I have just a question for you. So Giovanni, in which patients with IBS-related symptoms do you recommend broadening the diagnostic framework?
Yes, this is a very important question. It depends where we work. If we work in general practice, I would say just a few tests that I mentioned during the presentation. Obviously, if we have alarm features, weight loss, anemia, and so on, then we have to do all the tests that are required for that particular condition. If we at an age above 50, colonoscopy probably is important, as well as other tests. Apart from this particular situation, then I think that we should make a very early diagnosis and treat the patients, particularly in young patients with typical symptoms. And that is the best way to manage these patients. Remember, celiac disease and microscopic colitis, particularly in patients with diarrhea.
I see. Okay, perfect. Thank you. So I think that now we have a short video as interval just to relax for a while. I asked to our technical. Okay, it's perfect. It's starting.
Bromatech welcomes all participants to this international event entitled Microbiota and Gut-Brain Connection, a new frontier in neurogastroenterology organized in partnership with the European Society of Neurogastroenterology and Motility. It is a pleasure and honor for Bromatech to sponsor this important and unique scientific forum. Bromatech is a biotech company that conducts research into the properties of bacteria since 1985. At the forefront of development for probiotics for human use, Bromatech is now an established company with a clear product offering for the natural treatment of the digestive system. The bacteria in the microbiome help digest our food, regulate our immune system, influence our behavior, and protect against other bacteria that cause disease. The strain specificity and efficacy of its probiotic products differentiate Bromatech from other companies. Mastering the natural attributes of nature for a harmonious life is Bromatech's inner motivation. Nature can teach us much more than we presently know. Microbes inhabit just about every part of the human body. We humans are mostly microbes. Over 100 trillion of them live in our body. Microbes outnumber our human cells by 10 to 1. The majority live in our gut, particularly in the large intestine. Over the years, Bromatech has built a research team that constantly analyzes the use and properties of bacteria that form part of the microbiome. Advances in genome sequencing technologies and metagenomic analysis, that is, the genetic study of genomes taken directly from environmental samples, have enabled scientists to study these microbes and their function, and to research microbiome-host interactions both in health and disease. Partnerships with universities and other research centers provide a valuable source of inputs, as knowledge transfer between academia and industry is an important driver of innovation. By means of laboratory testing and relentless gathering of clinical data, the company continually develops its own formulations. Scientific works and medical literature support our products. The human microbiome has extensive functions such as development of immunity, defense against pathogens, host nutrition including production of short-chain fatty acids important in host energy metabolism, synthesis of vitamins and fat storage, as well as an influence on human behavior, making it an essential organ of the body without which we would not function correctly. Bromatech has a long experience in microbiota research that allows it to understand the interrelation of different bacterial strains and dose the right quantity for optimal results. This is done through a well-developed methodology that combines laboratory research, clinical trials, and modern production solutions. Bromatech is committed to education. Over the years, it has regularly offered to the healthcare professional community multiple educational programs on the properties of bacteria and their interrelation with human health. To promote advancements in the understanding of the microbiome, it has founded congresses, seminars, academic courses, and scholarships. The microbiome is dynamic and changes with early development, environmental factors such as diet and the use of antibiotics, and in response to disease. The complexity and plasticity of the microbiota is important in maintaining homeostasis with the host's immune system and has an important impact on the digestive system. Speakers from different fields have had the opportunity to address participants, sharing their clinical experience on the use of probiotics or presenting scientific research. An open debate is always welcomed at the end of each presentation, and participants stimulate discussions with their questions. Bromatech educational programs introduce medical professionals to the comprehension of this fascinating area of biology. Thank you for your attention and participation.
Okay, so we are quite at the end of the webinar, but I have some questions again from the chat. Two more questions for Giovanni. Hi, Giovanni. So one question is about IBS patients and leaky gut syndrome. So how many IBS patients having leaky gut syndrome?
I would say that many have it. I would say also that the methods that we have to detect leaky gut syndrome are not very efficient. So we can use in vivo studies with the sugars, lactulose and mannitol, but that is not a very sensitive way of measuring gut permeability. We can take biopsies and measure in using chambers, for example, the permeability, and also in other ways, and that is more sensitive, I would say. And in an early study that I think it was one of the first in IBS, we measured the permeability and also assessed the tight junction in the biopsies of patients with IBS, and we found that almost all of them, not only the IBS with diarrhea, but also the IBS with constipation, have an increased permeability with downregulation of certain proteins in the tight junction complex, for example, zonula occludens and occludin. So I think that many have this type of changes.
Okay, I see. Okay, another question is about the relationship, so the cause-effect relation between anxiety and IBS. So is it anxiety that causes IBS, or the contrary, is IBS that causes anxiety? L'uovo e la gallina. So,
the chicken and the egg. And yeah. If I knew the answer, I would be rich. Probably Ted Dinan could help us to better understand what is first.
No, I like you. I would hesitate to offer a precise relationship there. I mean, clearly, from a clinical point of view, IBS and anxiety disorders are comorbid, and that's the way we view them. We don't say that, look, I'm sure if somebody has IBS, but if somebody had IBD and they were suffering from anxiety, of course, their IBD would get worse. And if somebody has IBS and they're under stress, they too will get worse. But that doesn't mean that IBS is any more caused by an anxiety than IBD is.
Yeah.
Totally agree.
Yeah, right. So, other question, one is for both, I think. You can answer together. So, how to find a correct balance between the amount of fiber and in general, you could have also abdominal pain. So how to find a good balance between the amount of fiber and a good prebiotic effect? So how to find this? I can answer, I think.
Maybe what I can tell you is a story that a friend of mine in England told me some time ago. Peter Warwell, I think that Dinan knows him. Peter Warwell is a great gastroenterologist, and he tells me this story. This patient goes to the GP because using fibers for patients with IBS was very common in the past. And this patient goes to the GP, and the GP says, you have symptoms because you don't eat enough fibers. So he gives him a lot of fibers. And the patient goes home, and he started bloating and having abdominal pain, and it was terrible. So he goes back to the GP and says, look, I'm worse than before. And the GP says, because you are not taking enough fiber. And he gave him more fiber. So if you eat insoluble fibers, then you are likely to worsen abdominal pain and bloating. So generally, I never give insoluble fibers. I give a little bit of soluble fibers, and because these are important both for the functioning of the gut as well as for feeding the microbiota and having a good healthy microbiota. But I do not give too much fibers to the patients.
Yeah. I think Giovanni's advice for IBS patients sounds eminently sensible. I think for the rest of us, it's a question of if you don't have IBS and you don't have a GI disorder, then clearly, a balanced diet is what requires. And, it means an adequate amount of fiber, but not excessive amounts.
Yeah. So another question for Ted. Okay, have antidepressive drugs any effect on a microbiome?
An interesting question. We actually published a paper last year looking at a wide variety of psychotropic drugs and their effect on the gut microbiota. If you take fluoxetine, I suppose one of the most widely used antidepressants, it has antibiotic-like activity on the gut microbiota. It knocks out many different microbes. Interestingly enough, the one psychotropic drug that we found had a positive effect on the gut microbiota was lithium. Lithium actually increases gut microbial diversity, but most of the other drugs we looked at had a negative impact, usually decreasing diversity.
Yeah. Yes. Okay, I think that I have collected all the questions from the chat. So I thank all of you. I thank the speakers, Ted and Giovanni. I thank again the European Society of Neurogastroenterology and Motility for this webinar, which is a wonderful webinar. And so, see you next time, I hope in presence.
Thank you very much.
Okay.
Thank you very much, Paola.
Bye.
Goodbye.
Bye.
Bye. Ted.
Bye.